The next program is again we watch the gladiators, and this time two internationally acclaimed gladiators are with us, Dr. Dhiman Kahali and Dr. Soumitra Kumar. To monitor them, may I invite on the stage Dr. Monatosh Paja, Dr. Nirmallo Chakraborty, Dr. Shankar Pal Choudhury and Dr. Gautam Mistry, please. The time for the proponent is 10 minutes followed by 2 minutes rebuttal, and for against is 12 minutes straight.
Good afternoon, cheers, and good afternoon, ladies and gentlemen. Today I am going to talk about the necessity that after achieving the LDL target, in 2/3 of the patients we fail to reduce the residual risk. So this was an article in Science in 1996 by Dr. Brown and Goldstein that in 2000 there won't be any heart attack patients. But unfortunately, we see that there are a lot of patients. Just now I was busy in doing a primary angioplasty in a 60-year-old gentleman without any conventional risk factors. We'll search into it, what it is. But he has been admitted with an extensive anterior wall AMI with acute LVF with complete RBB pattern. That means the threshold for VT and VF was very low. However, we could open the artery very successfully. Now, beyond statins, this is the history. Forest trial was published in 1994 in the journal Lancet, and it is one of the pioneer trials where it has been shown that there was a total 30% reduction in total mortality, 42% reduction in cardiovascular mortality, and there was a 37% reduction in the revascularization rate in the form of either CABG or PTCA, and there was 37% reduction in heart failure incidence. But still you find that after reduction to such enormous quantity, there was some residual risk in this Forest trial population group. Same thing with Oscoff's trial, which was a primary prevention trial. There was a 31% reduction in the MIS and 24% reduction in the total mortality, and this is one of the successful trials. And there is legacy effect of Oscoff's trials that even at 10 years after cessation of therapy with statins, the good effect, the beneficial effect is still persisting. So we find from all the major trials that there is a residual risk in 2/3 of the patient, even after achieving the goal that is less than 70 milligrams or 50% reduction from the baseline LDL level. Now, these are the known and emerging risk factors for CHD. Many a times we don't find. I have 24 patients between the age of 20 and 28 who had a massive heart attack, but we don't know what was the risk factor. Now, this lipoprotein A is a very important risk factor, which is often neglected because it's not only atherogenic, but it is thrombotic as well. So it's a atherothrombotic risk factor, and we can find that there is increasing credence giving to the triglyceride molecule as well. Now, these are the treatment targets to address the residual risk in 2/3 of the patient. That's HDL raising agents, which has been largely negative trials with all the CETP inhibitors till now. This time also in ACC, one trial was presented, which was found to be negative. Now, targeting inflammation, we have been targeting by various ways, methotrexate, this and that. Triglyceride reduction, however, has been found to be very effective, and there has been a reduction in mortality like this Copenhagen CT study and many other trials which will come into the detail. And further LDL lowering, that is with the PCSK9 inhibitors or with ezetimibe in the IT trial, or obesity treatments or diabetes therapies. And lifestyle reduction and lifestyle modification measures are also very, very important. Now, these are the marker for future CV events. Among them, I think highly sensitive CRP is a very important risk factor, as we have found from the various trials, including the Jupiter trial, that where the highly sensitive CRP was substantially reduced, the benefits were much more than only reducing the LDL cholesterol. So I think this is a very important marker. Now, this from the Prove It outcome trial also we can see that the LDL-C and CRP, when it was below 70 milligrams and CRP below 1 milligram, we had the highest benefit, and we can see from the Kaplan-Meier curve that it was at the lowest level when both were reduced than either alone. Now, this is valid for the atherosclerotic progression as well by the various IVA studies, and you can find with lowering of the CRP, there has been halt of the atherosclerosis progression. Now, this is the Jupiter trial where there was a about 44% reduction in the event rate or risk factor with rosuvastatin 20 milligram for 2 years. And I think sufficient attention has not been given to this study, but there was a significant reduction with mortality reduction up to 65% when the LDL-C was below 50. That's what we are discussing today. And also the CRP was reduced significantly, and you can find that the p-value was highly significant, less than 0.401. Now, these are the effect of one molecule which has been used as an anti-inflammatory agent, and you can find they reduce everything: fibrinogen, IL-6, C-reactive protein, and this is the study CANTOS trial going on. This is an ongoing trial, and the primary endpoints you can find like the other trials, and the various dose schedules has been used. And so this is a picture where you can see that if we treat the inflammatory markers with the low dose methotrexate, there can be some benefit, and there is an ongoing trial, that is the CV inflammation reduction trial with low dose methotrexate 20 milligram and folic acid 1.2 milligram with a placebo control, and it has been published in AHJ. And high triglyceride, contribute to significant residual risk after statin treatment, and I think is very valid in our country. And the PROVE-IT TIMI-22 trial also showed that when there was a significant risk reduction, but there was a residual risk, and on treatment of triglyceride, the risk was reduced in this trial. Now, carriers identified with lower triglyceride and reduced risk for early onset MI, you can find that who have genes where the triglyceride is low, they benefit a lot in comparison to the patients with high triglyceride, that is 5 millimole or 350 milligrams of triglyceride against 90 milligrams of triglyceride. This is the ACCORD data where there is not much changes with fenofibrate, but in one group where the LDL cholesterol, where the triglyceride was more than 204 and the HDL was low, there was a benefit evident in this group of patients in the ACCORD trial. This is the meta-analysis where you can find that the hazard ratio improved, the relative risk reduced to 0.68, and it gained statistical significance with p-value for heterogeneity being 0.03. This is another trial by Steve Nissen and his group where they are giving statin full dose with omega-3 acid with fish oil, and the other group corn oil, to see 3 to 5 years follow-up, and these are the major main points. Now, these are the lipid lowering goals back to nature. You can find that if we reduce the estimated LCLC by PCSK9 inhibitor, we have found that the LDL cholesterol is going much lower, and these are the new trials that with lowering of the LDL cholesterol further down 50 milligrams or even lower, there is some benefit observed in many of the trials. This is another trial with the PCSK inhibitor Laplace TIMI-57, and you can see with lowering of LDL cholesterol there is increasing benefit. Now, this trial will be presented in the next AHA meeting next week, where I have also a lecture on STEMI Indian perspective. Now, with 40 milligrams of LDL cholesterol, what will be the IVUS appearance? That will be shown in this trial in the next AHA meeting next week. And these are the several trials which have already shown that with increasing lowering of the LDL cholesterol, the IVUS appearance of the atherosclerotic plaque volume reduces. Now, it is a risk factor, high triglyceride. Like smoking, triglyceride is also a risk factor, and we can find that triglyceride is mainly bound to the chylomicron on VLDL, which is called as a remnant, remnant molecule or remnant cholesterol in the Copenhagen CT study, and also little amount is present in LDL and HDL cholesterol. This is the Indian adiposity, and we have higher levels of low HDL and hypertriglyceridemia from this Indian study with 2,000 odd patients. Now, this Indian dyslipidemia is little different from the Caucasian or the Westerners, and the serum TG levels are higher and the HDL level is lower, and this is because of insulin resistance and because of abdominal obesity and other symptoms which comes. I am not going to detail this slide, but these are the things which occurs: high TG, low HDL, and increased small density lipoprotein. Now, is high TG associated with high CV risk? Now, these are some of the slides from the circulation where you can find that with increasing triglyceride there is increased risk, and this is another one published with 75,000 participants that with non-fasting TG less than 90 had 60% lesser risk of CV than TG more than 350 milligrams, and it was published in NEJM in June 2014. This is another article by the same group, the Scandinavian group, where they have shown in 14,000 patients in the Copenhagen City Heart study that triglyceride, in ladies especially with increasing triglyceride level, the mortality is more in the high triglyceride level of patient. This was findings from the Miracle study and the DAL outcome study, the same finding that with increasing triglyceride level, the CV risk increases. This is another trial where it has been shown the same finding and same methodology has been used. This is a very recent publication just published on 2nd of November. The CAN-HEART study with 63 lakhs patients were screened and 6 lakhs patients were randomized. Finally, you can find in the lowest portion, and it was seen that the mortality is highest with the lowest quantile of HDL cholesterol and also with the highest quantile of LDL cholesterol, HDL cholesterol, that is more than 90. But you know, with so it shows that the outcome was same so far as the CV and the non-CV mortality was concerned. So the conclusion was that probably high HDL cholesterol is not that much cardioprotective, but this was a very large study, and you can see that the CV death, cancer death, and other deaths were raised in both the quantiles, that is in the lowest quantile and the highest quantile. And this is the hazard ratio of mortality. The 22-hour mortality was very high, and you know it increased with increasing levels of triglyceride and lower HDL cholesterol level. Now these are the few studies from which we learned a lot regarding the outcome in the different trials. In the field design also, this group of patients who had a high triglycerides were benefited, and there was a significant risk reduction in this group of patients with the ACCORD trial with fenofibrate, whether as a whole there was no significant reduction in mortality. So this is a message that triglyceride, if it is more than 200 milligram per deciliter, then it becomes a residual risk factor, and it's very important to control. This is the ESC-AS guideline, but the 2016 guideline, they're given a 2A credence. I couldn't incorporate that slide, that in the ESC guideline, that if it is more than 200, then we should deal with the high triglyceride with some other molecule like fenofibrate or saroglitazar, which is going to be approved in 5 countries, including Australia and some Scandinavian countries. And this is the fasting triglyceride AAC recommendation 2005. This is our own recommendation. I am also in that guideline committee, and this is the Indian consensus statement. So to summarize, ladies and gentlemen, despite treatment with statin, substantial residual risk remains for many patients in 2/3 of the cases. Although many recent therapies have failed to show benefits, there exist many promising novel targets, including directly targeting the inflammation, reducing triglyceride, which has been found to be very helpful from different studies, as we have mentioned, and further lowering of LDL cholesterol is also beneficial in some of the cases, and raising HDL cholesterol is a thing which is to be seen in many other randomized trials. And thank you very much for your kind attention.
Thank you, Dr. Kali, for your opinion regarding the motion. Now I requesting Dr. Soumitra Kumar, you talk against the motion. You know that Dr. Soumitra Kumar, Professor, Head of the Department of Cardiology at Ramkrishna Mission Hospital. And he is working a long time in the lipid management. He has got enough experience in this subject. Dr. Kumar.
Respected chairpersons, my honorable opponent, ladies and gentlemen. The topic has already been introduced. My honorable opponent is a very busy interventionist. I am glad that he could just arrive in time for this debate. But the thing is that even for the stalwarts, at times we need to go to the basics. He made a very rapid transit through the slides. Some of these slides were there, but I would like to highlight some of the points. So these are the sum total of lipoproteins that we deal with: HDL, LDL, IDL, VLDL, and of course chylomicrons. And you can see that there is a progressive reduction in size from chylomicrons ending with HDL. And look at the percentage of proteins. Chylomicrons are very protein rich, 99% lipids, and HDL is 50-50 as far as lipid and protein distribution is concerned. And in between there is a mixture. Again, some basics. Summary of formation and fate of lipoproteins. Chylomicron is a transporter of dietary lipids, whereas VLDL is a transporter of endogenous lipids, mainly triglycerides. LDL transports cholesterol to peripheral cells, while HDL transports cholesterol from peripheral cells back to liver. What are the function of apoproteins? They can form part of the structure of the lipoprotein, like ApoB, structural component of VLDL and chylomicron. They can be enzyme cofactors like C2 for lipoprotein lipase, A1 for LCAT, ApoA2, ApoC3 for lipoprotein lipase, and so on. Or they can act as ligands for interaction with lipoprotein receptors in tissues like ApoB100 or ApoE for LDL receptor, ApoA1 for HDL receptor. This is a very important slide. As I told you, there is a progressive diminution in size from VLDL down to HDL. And you can see here that even in the LDL compartment, there can be 7 different sizes of LDL. But the point here is very important. You can see here that the big ones are not associated with atherosclerosis. That means VLDL is less atherogenic than IDL, it is less atherogenic than LDL. Now, less of HDL has a very peculiar relationship with atherogenicity, which I am going to deal with. But the thing I want to highlight that, as a matter of fact, LDL is the atherogenic molecule in this segment of lipoproteins. Now, this slide is going to relate my honorable opponent, triglyceride and cardiovascular risk, and you can see here that both fasting and non-fasting triglyceride clearly increases cardiovascular risk. Yeah, it's true. But the point lies elsewhere. But the point is that many of these studies were univariate analysis, and even in some of the studies, HDL levels were not measured. So we really do not know whether triglyceride levels alone accounted for the increased cardiovascular risk. The genetic studies have also linked triglyceride with increased cardiovascular risk, but the problem is that we do not know many of the function of these genetic variants. But still, it goes to show that increased triglycerides may indeed be equated with cardiovascular risk. And how is hypertriglyceridemia equated with atherogenicity? Triglyceride carries cholesterol and promotes atherosclerosis. VLDL is a precursor to LDL. High triglyceride, that is cholesterol enrichment of VLDL, is more atherogenic. It decreases LDL size, decreases LDL cholesterol, that is by way of formation of more of small dense LDL, and it also decreases HDL size because the dense HDL is also less protective as far as atherogenesis is concerned. And there are other ways how high triglyceride is linked to pro-atherogenicity: insulin resistance, endothelial dysfunction, pro-oxidative state, pro-inflammatory state, and pro-thrombotic state. You must be getting confused. Am I speaking in favor of the motion? Really not, ladies and gentlemen. Triglyceride is not directly atherogenic but represents an important biomarker of cardiovascular disease because of its association with atherogenic remnant particles and ApoC3. So it is at best a biomarker or a risk marker, not a risk factor. At this level, I would like to mention, do we really treat troponins or NT-proBNP or CRP? They are risk markers. They are not risk factors. All you treat are risk factors and the disease itself. So we really need not treat triglyceride, but need to treat the conditions associated with it. Some familial disorders of triglycerides, of course, are associated with very high levels, like more than 1000 milligram. There we need to treat triglycerides just to prevent pancreatitis. Others are associated with increased atherosclerotic risk only. Now here is the sum total of all the studies carried out with triglycerides. You can see here, I will not go into the details. Now they had some primary objectives which are common, like MI, coronary heart disease, death, and non-fatal stroke. You can see here, with the exception of Helsinki heart study, none of the primary objectives required, met with any statistical significance. Of course, in the subgroup analysis, high triglyceride and low HDL, in that subgroup of almost all the trials, some statistical significance was reached. But mind you, those were only subgroup analysis, and we do not, it can be as best hypothesis generating, but it cannot dictate any treatment. Now, following this, we had this meta-analysis published in Lancet, Effect of Fibrates on Cardiovascular Outcomes, a systematic review and meta-analysis. And what did it show? You can see here that with the exception of coronary events, where 13% relative risk reduction was met, in terms of other parameters like all-cause mortality, cardiac death, cardiovascular death, sudden death, total stroke, it was unequivocal. Only in terms of retinopathy, there was some changes. So largely in the meta-analysis, treatment of triglyceride with fibrates did not achieve any significant endpoint. And as an Achilles heel came this, fibrate-induced deterioration of renal function. Not only did that meta-analysis show this, but in this article in the Nephrologia, it was shown that these people had encountered 13 cases of fibrate-induced acute renal failure in 2 years or so. And 4 out of these 13 patients actually had a non-reversible renal deterioration. And you can see here from data from one of such patients that every time fibrates were added, there was an increase of creatinine along with decrease of triglyceride. Whenever it was withdrawn and re-added, the same thing happened. So fibrates and nephropathy. Most clinical studies have shown a rapid, within weeks, raising effect of fenofibrate on serum creatinine. Risk predictors are increased age, impaired renal function, high dose treatment and concomitant medication like RAS blockers. Possible mechanism is inhibition of renal vasodilatory prostaglandin, resulting in reduced renal plasma flow and glomerular pressure. And look at the world guidelines. With the exception of European Atherosclerosis Society and the American Endocrine Society, US Endocrine Society, all the major international bodies, be it ESC, be it ACCHA, be it British societies, all and even the ADA, they say that there is no benefit of reduction of mild to moderate elevated triglyceride in terms of reduction of cardiovascular disease. So overall treatment of elevated triglyceride mainly focuses on therapeutic lifestyle measures that can result in reduction of triglyceride by as much as 50%. You can see here, this is the overall flow chart, how you can achieve reduction of fasting or non-fasting triglycerides by lifestyle measures. I will not go into the details. So overall, we only need to give drugs when the triglyceride level is more than 500, and it remains to be established whether triglyceride lowering modalities favorably influence cardiovascular disease outcomes beyond proven therapies like statins. Additional trials are indeed necessary. Now let us come to the other lipoprotein, the HDL. Yes, irrespective of any LDL level, low HDL adds to the risk, and with reduction of HDL 1 milligram per deciliter, there is almost a linear increase in cardiovascular mortality. It's true. But you have also heard the Canhart trial recently published. High HDL is also not protective. It can lead to increased non-cardiovascular mortality. Now this is the sum total of the niacin trials. I will only go to the meta-analysis. It does show before the MHI and the HPS2 thrive, which I am going to show, it was going in favor of niacin. You can see here that overall there was a 25% relative risk reduction with niacin for the odds ratio for coronary heart disease. But then came the blow. With MHI, there was no difference with the addition of niacin to simvastatin versus simvastatin alone. And same thing happened with HPS2 thrive. The niacin laropipran combination versus placebo was almost, it was a negative trial. In fact, in Chinese patient, there was more of myopathy. And it is not only niacin which failed, be it fenofibrate in accord, be it the various CETP trials, or be it the aliglitazar. You can see here on the right that the main reason where all the trials were stopped was the reason was futility. And the reason is HDL is a really mystery story. They differ in terms of particle shape, in terms of apolipoprotein composition, and in terms of various particle sizes. HDL3C may not be at all cardioprotective, whereas HDL2B is the only one which is cardioprotective. So we really need to look at the HDL function, not the quantity. Cholesterol efflux capacity may have more closer relation with cardiovascular disease events. So where do we stand? Robust inverse association of concentration of HDL-C and CVD events is proven, but long-term studies have failed to show any benefit of raising HDL. Niacin, fibrates, phenofibrates have been successful in some subgroup of patients with elevated TG and low HDL, but not in the overall population, and they are only subgroups. We mainly focus on lifestyle intervention for HDL now, and we remember that HDL cholesterol is not equivalent of HDL particles, not equivalent of ApoA1, and not equated with HDL function. So we really do not know what the future for HDL is in store for us. Right now, ApoA1 infusion has shown some benefit. We have to wait for more results. The last lipoprotein I'm going to talk of is Lp(a). You know its background in the Indian scenario. Some therapies are useful like niacin and lipoprotein apheresis. Recently, PCSK9 inhibition has also shown to be useful. However, there is no study investigating the effect of these agents on cardiovascular events. So, ladies and gentlemen, the non-LDL, mind you, non-LDL conundrum in cardiology persists. We can neither digest them nor get rid of them. So I will conclude with this quotation. I quote, it is wrong always, and I repeat, it is wrong always, everywhere, and for everyone to believe anything upon insufficient evidence, I unquote. Thank you very much for your patient hearing.
Thank you, Dr. Kumar, for your beautiful speech regarding the topics as an opponent of this motion. Now, Dr. Kaheli is invited for 2 minutes. He's been allotted 2 minutes in favor of some additional points.
Thank you very much, Shaumitro, for your wonderful speech. I have got very, very high regards for him as a professor and cardiologist. Now, he was a little confused that how TG is atherogenic. I would refer Shaumitro to an article published on June 16, 2014 in NEJM by the group I mentioned, the Scandinavian group I have shown in the slides also. The TG is atherogenic. They are calling it as remnant cholesterol and TG along with chylomicron and VLDL. When they are out of the blood, they are inactive, but when they come in the blood, triglyceride comes out, and this remnant cholesterol penetrates the endothelium and it gets deposited in the wall of the arteries. So it is same atherogenic as LDL cholesterol. So that's the number one answer to him. He is worried about the pancreatitis, and he calls TG as a risk marker, not a risk factor. But I have shown from several studies, including the Copenhagen CT heart study, the other trials like the DAL outcome trials, the IT probe, and all the sub-studies have shown substantially that triglyceride is a risk factor, and there is substantial increase in the mortality in the group where triglyceride is more than 204 milligrams per deciliter, and if they are treated, there is mortality benefit and risk benefit, and there is a substantial risk reduction up to the tune of 31%, even in the ACCORD trial and the field trial of group of patients. Now, he mentioned about fibrate and ARF. We know that fibrates may cause some complications, but it's not that fibrates are the sole treatment of triglyceride. In the same breath, he has mentioned that triglyceride can be controlled, even the severest of hypertriglyceridemia, with proper lifestyle modification measures, and that is true. And I believe that if we employ weight reduction, low saturated fat diet, restriction of sweet, control of diabetic status, many of the hypertriglyceridemias can be controlled. And our aim is not complications of fibrate, but to substantiate that hypertriglyceridemia in many times along with low HDL cholesterol is a great risk factor for coronary artery disease and mortality thereof. I would also refer Shaumitro to another article published in August 18 in Lancet, where 75,000 patients were screened, and they showed the same thing, that triglyceride is as atherogenic as the LDL cholesterol. And I would also remind my great friend, that he didn't mention about the ESC 16 recommendation regarding the lipids, and you will find in the ESC 2016 recommendation that they have recommended if the LDL cholesterol is if the TG is more than 200 milligrams per deciliter, we should think about lowering the triglyceride level. So it is recommended not only in ESC 16 but in the AACE guideline and also our own guideline, that is the Lipid Association of India guideline, and many other guidelines are going to follow through. So there is great evidence that hypertriglyceridemia is a risk factor for coronary artery disease. It increases the complication, it reduces the risk if it is lowered in those population where we have come to the lowering of the LDL cholesterol to the desired level. Also, he didn't mention willfully that further lowering of LDL cholesterol is also beneficial. We mentioned about that. We mentioned about PCSK9 inhibitor, which also reduces LPA level and which also reduces triglyceride a little and also increases the HDL cholesterol, and that's going to be a great molecule. I am also involved in the Odyssey outcome trials, and the results are very encouraging. I saw the Laplace 57 trial, which has been very encouraging, and with increasing lowering of the LDL cholesterol, increased benefits are being seen. Similarly, increasing the HDL cholesterol is also beneficial, and I showed from the latest trial, that is the CANHERT study with 6 lakhs population where 63 lakhs patients were screened, just published 3 days back online in JAG, that keeping the LDL cholesterol between 50, 60, 70 like that, it's beneficial, and the mortality is low in those group of patients. But not only the CV outcome, he mentioned about the non-CV outcome. In the highest quantile also, the non-CV as well as the CV outcome were increased. So to summarize, ladies and gentlemen, we have come to a state that after adequate control of LDL cholesterol, there is a substantial residual risk in 2/3 of our patients, and there had been several studies like treating the inflammatory markers. We have shown it like colchicine. There is one trial that a small dose of colchicine also reduces the event rate. So I believe that hypertriglyceridemia, the level of HDL cholesterol and further lowering of LDL cholesterol, along with the modification of lifestyle measures, are very important in reducing further residual.
Thank you, Dr. Kali.
Kind attention.
Dr. Soumitra, anything against the last comment of Dr. Kali? Just no. Then I cost anything add, and then we'll hand. Anything.
In fact, at one point when my esteemed senior colleague Dimanda was speaking, I thought he was speaking on my behalf. I mean, he himself mentioned that triglyceride is a risk marker, not a risk factor. Now, yes, it is. Triglyceride is bad, I know. But simply trying to lower triglyceride or raising HDL is not the answer. So we have to find the answer. So probably in another forum, we'll try to find the answer. But for the time being, trying to treat high triglyceride and low HDL with drugs is just not on. Thank you very much.
Okay, thank you. Both these speakers work their own point, and they justified their statement. Anyhow, you have to, practical point of view, you have to decide for your own patients. So accordingly, you have to treat your patient accordingly. Thank you very much. Both the speakers done the wonderful job for us. Thank you.
Thank you. Thank you, the speakers and the chairperson.